Hi everyone, this is Dr. A with Chapter 13 of Nile's Basic of U.S. Healthcare, looking at the beginning part of the chapter on mental health issues. The actual back half of it's for my class is an assignment for homework. So we're going to look at alternative approaches to mental health care, mental health issues in high-risk populations, post-traumatic stress disorder, and evaluate the importance of the National Institute for Mental Health and APA also for mental health care. So, did you know surveys indicate that 1 in 4 Americans suffer from a mental disorder in any one year, and over 50% of students that are age 14 and older with a mental disorder drop out of high school, which is again the highest dropout rate for any disability group. And mental health ranks second to heart disease as a limitation on health and productivity, so definitely something that can impact our economy. So this little video I'm actually going to link below. It's just a little video about breaking the stigma to mental health, and I do want to address that for a second, is that we don't stigmatize people for having diabetes, for having heart disease, for having cancer, yet we tend to stigmatize people for having mental health issues, and we just need to look at it as it is a disease like any other disease. It's something that can be remedied often, that can be managed, and so again, we need to break the stigma. So the World Health Organization states that mental wellness or mental health is an integral and essential component of health. So, you know, the health is not just about the body being healthy, it's about the mind, it's about outlook on life, it's about all of it together. So mental health issues can be caused by a variety of causes. They can be biological, they can be psychological, and sometimes it could be personality factors. And so just sometimes the thing is with the stigma around mental health is there may be a biological issue and that could be remedied. Sometimes it could be a cyst or a tumor or something, or a chemical imbalance, or just imbalance in neurotransmitters or something like that, and that could be addressed. And so, but unless the person seeks help, it's kind of hard to get to the root cause of what's going on. And mental disorders are the leading cause of disability in the United States. So tell me what you think if you're just on video, watching a video. So what is a mental health myth that you've heard? So there are lots of mental health myths out there, and some of them are like only certain people get mental health issues. They can be also that it's a flaw in your character of some sort. That's definitely a myth. So think of myths. And first we're going to delve into the history of U.S. mental health care. So initially, mentally ill individuals were simply cared for by their families, same way as initially elderly people were simply cared for by their families. But then the state started to build insane asylums. They were later known as hospitals. In the mid-18th century, the state of Pennsylvania opened a hospital in Philadelphia where the mentally ill could be housed, but they were housed in the basement. So again, not the best treatment there. During this period then, Virginia was the first state to build an asylum, and if the mentally ill were not cared for by their families or sent to the asylum, then they were often found in jails or in almshouses, so poorhouses. It was not until the 19th century, so the 1800s and stuff, that the mentally ill were started to be treated with sensitivity, and this moral treatment approach started earlier in Europe with success. After World War I, many war veterans returned home with mental disorders, or what is now known as PTSD, post-traumatic stress disorder. So before that, it didn't really exist. It was not until the 1930s that medications for mental health treatment became available. So it's pretty recent, really, when you think about it in the grand scheme of things. Other controversial treatments were used, such as electrotherapy, brain surgery, or lobotomies, which well, not effective. World War II further focused the government on mental health issues, and the National Institute of Mental Health was created. And that's been a lot of help. So I want to show this one. So this is what they call shell shock. So this is the post-World War I shell shock. So I'm just going to play it. It's just music and text here. Sorry, Justin. So this veteran or the soldier had shell shock. So you can see definitely some very physical effects there. That was some of the treatment they were trying to do to help these patients with shell shock. And they were having some trouble walking, that specific gait they had. So again, those are some of the expressions and stuff that were typical of somebody with shell shock. So hysterical gait, swaying movements, nose wagging tics, and the film then was taken after admission here of this person. Shell shock. And so this is all, after coming back from the war. And try to help them get back to normal. So here's another expression of it. That's what he expressed, for PTSD. Again, with improvement with therapies and stuff. So anyway, we're going to move on from that so you can get an idea. So I want you to reflect on that and see what was different about World War I, because that was not the first, war as compared to previous wars, such as the Civil War, that caused so many soldiers to suffer from shell shock, which is back then it was a brand new condition, which is now known as PTSD. So carrying on then, by the mid-1950s, over 500,000 mental health patients were being treated in government mental health hospitals. So that's, some progress. And in 1952, the American Psychiatric Association published its first DSM, which is the manual with all the diagnostic criteria for all the different mental health disorders. And this was, a good, first publication, and this was coordinated with the World Health Organization's International Classification of Disease to encourage acceptance of mental health disorders. Again, not to be seen as character flaws. So finally, the first psychoactive medication was developed that could allow outpatient treatment of mentally disabled patients. In 1955, the U.S. Commission on Mental Health was established and investigated the quality of mental hospitals and allocated funds for outpatient facilities, because obviously probably people would rather live at home than to be institutionalized. As more psychotropic medications were developed, Congress provided more funding for community-based services. Medicaid, Medicare, Social Security, and disability insurance became accessible then for mental health care, which that was good progress right there. Over the past centuries, the mental health system has consisted basically of a patchwork of services that has become very fragmented. And mental health problems obviously impact not only the individuals, but the family members that have to care for them, and friends as well, especially, of course, if they can't work, then somebody's got to care for them. It costs money to live and stuff. So, and then, if they're having a crisis, an issue, it's definitely also a drain sometimes on the family, just even mentally, emotionally. As a result of the vast impact of mental health disabilities, behavioral services are provided by psychiatrists, psychologists, social workers, nurse, counselors, and therapists. And so if mental health is something that is of interest to you, there are many, many avenues to get to that. And so psychiatry, though, requires med school, so it would be an MD. And for psychologists, you have to have usually a doctorate in psychology. Social worker, there's a lot of different social work programs. A lot of times they're either a bachelor's or a master's level. Nurses can do a subspecialty in mental health. And then counselors and therapists usually have a degree in mental health counseling or something. It's usually a master's, and it can be licensed therapist. So approximately 75% of suicides occur in low and middle income countries, and about half of mental disorders begin before the age of 14. So again, suicides due to mental health issues and stuff is usually, again, poverty is a factor in that. Mental disorders are the leading cause of disability in the U.S., and mental illness can impact individuals of any age, race, religion, or income. And so that could be some mental health myths that only a certain age, only a certain age range, suffers from mental health issues. It's just not everybody can suffer from mental health issues. In 2014, an estimated 44 million adults aged 18 years and older experienced serious mental illness. And access to mental health services has been limited, partly due to myths associated with mental health problems and partly due to the treatment of mental health illnesses, some successful, some less successful. Okay, so next question I want you to think about. So we're going to look at this here. I'm going to click over, so give me a second here. It's going to go here. So this is a map with countries with low suicide rates and high suicide rates. This is about suicide being the leading cause of death, especially in young people. And so here's the global distribution of suicide. So you can see the darker ones have the most. And here, there, and then the lighter ones here have the least. And so you can see, so what country that doesn't have a lot of suicides here, for example, are these lighter countries, so like Mali, but then, here we go, Indonesia, then we can go some of the lighter colored ones here, Pakistan, or Turkey, or Spain. For the most, probably being Greenland, Guyana, very poor. So there you go. I just wanted you guys to get to see that. And so let's go back to our question. I'm going to put this back into full screen. So again, so basically look at that and then list a country that has a low suicide rate and one that has a high suicide rate. So let's talk about categories of mental illnesses. There are two broad categories of mental illness. There's the AMI, which is any mental illness, and it's a mental, behavioral, or emotional disorder. The majority of your common mental illnesses are going to be an AMI. A serious mental illness, however, SMI, is also mental, behavioral, or emotional, but it impacts how patients function in daily life. So, for example, having really bad schizophrenia could be SMI, considered an SMI. And sometimes it can be one or the other. So, for example, if a patient that would have, for example, autism to the point that they're like nonverbal and non-communicating and not really functioning well, then that might be an SMI. But there's such a variety in autism, and so there are some autistic people, of course, that can function very well in society, hold down jobs, maybe live on their own with some supervision and some help, and that would be more of an AMI, obviously. So, but the majority would be AMI. Having depression would be an AMI, but having a complete mental breakdown would be an SMI, where hospitalization is required. So let's think through some of these and take a guess where you think it's an AMI or SMI. So autism, again, there's a spectrum. So if you would think an autistic person, AMI, SMI, what would you think? Depression, AMI, SMI, so just this run-of-the-mill depression. PTSD, AMI, SMI, what do you think? And bipolar, manic depressive disorder, AMI or SMI, and ADD, AMI or SMI. So what do you think? And honestly, on some of those, one more, OCD, AMI or SMI, it's really going to depend on the level at which the disease is expressing itself and how much it interferes with a normal life with daily functioning, daily tasks. So the prevalence of AMI is higher among women. Young adults, 18 to 25, have the highest prevalence of AMI at 22%, compared to those that are 50 and older, which only have 14.5%. So in 2016, 64.8% of adults with a severe mental illness received treatment. That's not enough. There's not enough people that have severe mental illness accessing care. And what is treatment defined as? It would be defined as an either inpatient or outpatient, either counseling or being treated with prescription drugs, where the condition is then considered obviously to be as being managed. It doesn't mean there's not any symptoms, but it's being managed. The 1999 Surgeon General's report on mental health defines mental disorders as conditions that alter thinking processes, moods, or behaviors and result in a dysfunction or stress. The condition can be psychological or biological in nature. The most common conditions will include phobias, which are excessive fears of objects or activities. The next most common is going to be substance abuse, and then the affective disorders, which are emotional states such as depression and anxiety. Anxiety would be an affective one too. Now I'm going to link this TED Talk below. I highly, highly encourage you guys to watch it. If you're in my near productivity, it'll be part of your assignment. And this is Daniel Amen. He has got some really neat approaches to mental health, including a lot of brain imaging. He has a lot of resources and a lot of even alternative treatment methods that work really well. He has a few books out. Some of the latest ones are The End of Mental Illness and Your Brain is Always Listening. But he has more works out. So anyway, I'm going to link it below for the guys that are on YouTube. If you're in my Nearpod, you're going to have to listen to it. And you will have them skip this quiz. You'll have to answer some questions based on that. But just the TED Talk in itself is worth watching. So the Mental Health Parity Act, so this is going to be legislation, right, was passed in 1996 to ensure adequate coverage for mental health illnesses and mandate that annual lifetime reimbursement limits on mental health services were similar to other medical benefits. And then about 10 years later, the Mental Health Parity and Addiction Equity Act further supported mental health care by requiring insurance plans to offer mental health benefits and cost sharing similar to those of traditional medical benefits. So again, mental health being folded into with your healthcare coverage and stuff. And they've even, I know personally, like some of the stuff that we've happened was like, yes, they incorporated it and was covered, but at first it was like, oh, but you got to meet your deductible, and so you're gonna have to pay, $500, $600, $700 up front before you can, even just to begin to get care, to get into the system before the benefits kick in. Now, thankfully, our insurance has improved, and a mental health visit is the same as a doctor's copay, so that really is good progress, I think, personally. So, who provides mental health services? So the book has a little bit about the de facto mental health system, so where all it's accessed. So it could be accessed through primary care. Sometimes it can be accessed through counseling services. It can be, sometimes, people show up in the ER, so that again would be like the hospital. And families often, are the ones that prompt the person to get help because they provide support to their mentally ill family members. So family is still the structure that props these people up and helps people with mental health issues. So primary care providers often detect mental health issues and refer patients to specialists. So it's always worth talking to a primary care provider about problems and feelings and things with depression. Even if they may not be qualified to help you right then and there, they can at least guide you and get you in the right therapy, maybe the right medications and things. So psychiatrists are specialty physicians who have an MD. They can prescribe medications and also admit patients to hospitals. Likely, if somebody is being seen in ER for mental health issues that are especially really needing prompt intervention, a psychiatrist is who's going to see them, or at least be consulted. Psychologists also participate in the treatment of mental health. They, however, cannot prescribe drugs because they do not have a medical doctorate. But so they provide different types of therapy. So talk therapy could be, for example, one of them. But there, I mean, I'm sure there's a variety of therapies there. Social workers, they focus on mental health counseling. They can also help connect people with services, and they, they can work also with children, and so they definitely have a huge, impact on mental health. Nurses can specialize in psychiatric care. Again, it's just a subspecialty of nursing. And then additional counselors, therapists participate also in the treatment of mentally disabled people. They can do group therapy, they can do individual therapy, and so there's a lot that can be done there to help people. The National Alliance on Mental Illness, or NAMI, and the Mental Health America are both nonprofit organizations that can provide education and support for the mentally ill. And so a quick question. So of these professions we talked about, which one might be interesting for you if you think mental health is interesting? So again, there's so many different avenues and ways to get to participate in mental health treatment. What's interesting? So the mental health commitments law, so there's a difference between voluntary and involuntary commitment. So voluntary commitment occurs when people commit themselves willingly to receive care. If a person voluntarily commits for treatment, that person can leave of his or her own free will. So this is sometimes typically see somebody maybe going into rehab because they're having some problems with substance abuse of some sort, and they've decided it's time to get better, get healthier, do better by their family, and so they voluntarily enroll in a rehab program. Involuntary commitment occurs when people are being forced to receive treatments, or they are committed to a facility against their wishes. And so this can be often done with people that, because of their mental state and the mental illness that they have, you cannot reason with them, but they need therapy, they need help. And so that would be, and it could be definitely a threat to themselves or to other people, and so they might be involuntarily committed. And that would be obviously a decision of a mental health professional such as a psychiatrist. So another little poll question. So which one of these would be, do you think, an example of involuntary commitment? So a 72-hour psychiatric hold for attempting suicide, a court-ordered inpatient treatment for a mental illness or breakdown, or an assisted outpatient treatment, so, or all of these. So which one? It could be involuntary commitments. All right, private and public funding. So Medicare and Medicaid are large sources of mental health funding, particularly for those who have serious mental disabilities who cannot work. So cannot work, they're on disability, they're probably automatically going to be either on Medicaid or Medicare. Medicaid is the single largest payer for state financed mental health care. Again, because a lot of times people can't work with serious or mental health issues that affect life. So a little bit about managed care. So managed care organizations can contract with external vendors that can focus on mental health care. So again, a lot of times managed care organizations with physicians group with hospitals, and then just mental health wasn't a part of it, and hospitals aren't really specialized. Your run-of-the-mill hospitals usually not specialized to provide mental health, and so this is something that they will contract out with deals for cost management, cost control, and stuff. So and so these external vendors have become known as managed behavioral healthcare organizations. Okay, so this is where we end this lesson. So if you have any questions, let me know. For people in my class, the other half of it is going to be in your homework. So again, thank you for paying attention to this short lesson and overview of mental health. I'll be linking the videos I mentioned below.